Okay. How are we? Hello? Tired. Really? Are you? I don't know why. This is term 5. Why are you tired? All right, you guys. Um, so I want to go over, first of all, are there any, I don't know that we can hit everything in an hour. Um, are there things on this list for sure that you want to go over?
Miss Tina, it's not letting us type in the chat.
It's not letting you type.
It says you can't send messages because you're not a member of the chat.
It says what?
It says you can't send messages because you're not a member of the chat.
Oh, because you're outside of the organization.
I used my Concord email.
Huh?
I used my Concord email.
Yeah? Because some people are typing, so I'm not sure. But I have a message here. Some people in this chat are outside your organization. It's possible they have message related policies that will apply to the chat. Okay. Well, if you can't type and you want to talk, raise your hand and that way I'll know, okay? Because I'm not sure why it's not letting you type. Okay, so topics on here you absolutely want to go over. Direct and indirect coombs. Okay. So
Acceleration.
the acceleration, deceleration.
Yeah.
Okay. So veal chop. Okay. Okay. So direct, indirect coombs, let's talk about what it pertains to, right? So number one is we're talking about RH incompatibility, right? Specifically, mom is RH negative, baby is RH positive. What is mom going to produce as a result of that?
Antibodies.
What kind of antibodies?
Rh positive antibody.
RH positive antibodies. Okay, RH positive antibodies because these this RH, this positive RH came to a negative mom, which was basically an antigen. So mom made RH um, positive antibodies so that when she sees RH positive again, she will attack it. Specifically, what? What is that attacking specifically? Red blood cells. Very good. Baby's red blood cells. So the RH positive antibodies attack baby's red blood cells. So baby's getting broken down red blood cells, broken down red blood cells, broken down red blood cells. Baby gets what? What's baby have now? We'll end up with jaundice, but first, before I get jaundice, I get anemic because I don't have these red blood cells to carry oxygen, so I'm anemic. And then my red blood cells, I hang on to the heme because that's where my oxygen is, and I get rid of the byproduct, which is what's the byproduct of broken down red blood cells? What gave me jaundice?
Excess bilirubin.
Excess bilirubin. The byproduct of broken down red blood cells is bilirubin. Bilirubin goes up, 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 baby gets jaundice. Okay? So baby has this anemia. So what does baby's body do? Releases what? Yeah, they're going to turn yellow, but what is baby's body's response to low red blood cells? Spit out immature red blood cells, right? It's going to spit out what blood cells it has in the bone marrow, which are going to be reticulocytes, otherwise known as immature red blood cells, and the baby's going to get more and more anemic, and the baby's going to go into heart failure. Okay? While that's happening, bilirubin is going up and up and up and up, and my baby is born jaundice. But in addition to that, what does my body do? What does baby's body do if it gets higher, higher, higher bilirubin in the blood? It won't let it stay there. It wants to put it somewhere. So where does the body put it?
The urine.
That's where it's being broken down to and excreted. But the part that's not being excreted, very good, Destiny, goes to the brain and causes brain damage known as kernicterus. Very good. So now I have kernicterus. So back to our direct, indirect Coombs. Think about, am I directly measuring or indirectly measuring? So Coombs in and of itself is measuring those autoantibodies, the antibodies that mom made. So a direct Coombs test comes directly from baby's blood. In other words, the sample comes from baby. It tells me exactly how much Rh positive antibodies are present that are attacking the baby's red blood cells. That's a direct Coombs. Indirect Coombs is I measure mom's level of Rh positive antibodies. And because of that, if mom's levels are high, baby's levels are high, mom's levels are low, baby's levels are low. Got it? Okay, let's talk about jaundice. What is jaundice when it appears at birth? Pathologic. Very good. Pathologic. It is a pathogen. Something is causing it. One of the things that causes it is this Rh incompatibility. One possibility. Another possibility is hepatitis or any other liver problem that the baby has. All of those, the baby could be born with jaundice. Okay. The other one is physiologic jaundice because the baby is physiologically immature. So, baby is born, and 2 to 3 days after the baby's born, remember the day that baby's born, baby has to take care of its own destroyed red blood cells, right? So it's taking care of its own red blood cells, but we already know the liver's immature, which is why we had to give vitamin K because it doesn't have all the clotting factors yet. Liver's not able to keep up with the bilirubin in all cases, so the bilirubin goes up. And so physiologically, the baby is not mature. So after about 3 days of trying to meet the demand to break down all these red blood cells, because remember, red blood cells are dying every single day and being replaced, baby can't keep up. So a few days after birth, they end up with jaundice because of their physiologic immaturity. So I treat that with phototherapy. What are the things I have to remember as a nurse about phototherapy? Some big things. We have to turn them so that all different
Okay.
parts of their body gets exposed. They have to have eye shields on before you turn on the Billy lights. And another biggie. Well, two biggies actually. Three, really. Cover the genitals, very good. And Bang.
Remove during feeding.
What'd you say? I'm sorry.
I was gonna say thermoregulate them, so keep them warm.
You have to keep them warm. That wasn't the one I was thinking of. What'd you say, Raiden?
I thought I remove the ice patch during feeding, like feeding.
You, as long as they're under the Billy lights, they have to have the eye patch on. So as long as they're under the Billy lights, they have to have that on. Very good, Sin. It's hydration. You gotta have a hydrated baby if we're gonna do phototherapy, because what is phototherapy doing exactly? Well, it is radiation in terms of its sunlight. That's true. Right, Sin. It's turning the bilirubin into water soluble so that the urine can excrete it. You get rid of your bilirubin in your stool. That's why our stool is a brown color, because that's coming from partly from bile, partly from broken down bilirubin. We get rid of ours in our bowel. Babies get rid of the excess by the sunlight breaks it down through the skin into a water soluble form so it can be excreted into the urine. So they have to be hydrated before before we do it. Okay. Okay. What else? Oh, the veal chop. So, as a VN, you can get out of just about any question you're going to be asked by memorizing veal chop. Okay? So, if your question talks about variable decels, you know that V goes with C, which means it's what? Chord compression. Very good. And if it is E or early decels, it goes with H, which is head compression. So you get the idea. So most of the questions that you would ever be asked are going to be related to that. Other things to be aware of, though. What is your responsibility if you are, if you're an outpatient and you have a mom doing a fetal stress test, for example, which you can certainly set up and check on a woman who's doing that. What is your responsibility if you are in a monitoring state for a woman who is on a monitor? What's your legal responsibility? Yeah, record it, document it, and report, right? If you see late decels, you see variable decels that aren't getting better, you have to report those things because baby's in trouble, right? If you're looking at a possible prolapsed cord, what are we going to do about that? So P goes with L, right? So I have late decels. So I have to worry about possible um, prolapsed cord. So what do I do if my mom has a possible prolapsed cord? I can Trendelenburg her, but the easy one is knee to chest, right? If I put her knee to chest, um, if you've got a cord that's physically coming, if a woman's water breaks, your first priority is look at the monitor if they have one, check for a prolapse cord if they don't. And if you see a prolapse cord, what are you supposed to do? You can put them knee to chest, but you can also glove up and push the head off of, glove up, push the head off of the cord. And then have somebody else call the doctor. You don't leave the patient and call the doctor. You've got to get that baby off of that cord because otherwise you're going to have a dead baby. So we need a Chestum, Trendelenburger, and if they actually have a cord protruding, we have to vaginally push up on the head and get somebody to call the doctor. And we're going to do this until we get them in for an emergency C-section. Okay? Because that is a medical emergency because the baby's going to become hypoxic and die, or unfortunately have cerebral palsy, which we'll talk about next week. Okay? So we do have to worry about that for sure. Okay, what else? Oh, you also need to know so your mom might be in trouble. What are your top 2 interventions? First, you do what? Yeah, if I'm looking at a monitor, mom's in trouble, what do I do? Give oxygen, very good. How much? 8 to 10 liters. Yeah, 8 to 10 liters. O2, and then turn her to her left. Yep, modified side lying. So tilt her to her left so that baby gets oxygen. So big things with fetal monitor, be able to recognize each of the rhythms, either the variable early or late decels based on what you see on a monitor. Be able to respond to if you see early decels, late decels, variable decels. And again, knowing veal chop left side or O2 left side, and what to do the given. Yes, O2 at 8 to 10 liters is a standing order for women in labor, because if we don't get oxygen on board, we could have a dead baby. So yeah, that's a definite that we have to do that. Okay. All right, so we talked about jaundice, we talked about RH incompatibility. Let's talk about gestational diabetes, gestational hypertension. So, my mom comes into the pregnancy with diabetes. What is my nursing care going to consist of? Yeah, my mom comes into the pregnancy with diabetes. What do I need to do, say, teach? What's going to be happening? Baby will be hypoglycemic at birth, potentially, and will be bigger than average, yes. And increased insulin needs if she's on insulin. What about if she's on oral antidiabetics like metformin, glyburide, diabetes, something like that? What do I do? Or what's going to happen? Right. We
Does
have
she
to
have to stop them?
discontinue. Have to discontinue the oral meds. What were you going to say, Mojbing?
Oh, that's what I was gonna say.
Okay.
To
So
stop
we
them.
stop the oral meds, start her on insulin. Why can't she take oral meds? Yeah, they cross the placental barrier and they're potentially teratogenic. So she can't have those. Okay, mom gets diabetes and she's 16 weeks pregnant. What kind of diabetes does she have? She does not have gestational diabetes. What's the dividing line for gestational hypertension or gestational diabetes? 20 weeks. 20 weeks. So if she gets diabetes prior to 20 weeks, then it's going to be type 2 diabetes. If she gets diabetes after 20 weeks, then she has gestational diabetes. So 20 weeks is always a big deal. So again, adjectives matter. Pay attention. There's going to be several questions tomorrow that talk about what's your priorities. Okay. Always remember when something asks you about priorities, it means there's at least one answer that's correct. Your job is to figure out how many are correct and rank those. Okay. So there will be multiple questions that ask you for first, most important priority. Always remember more than one answer. Find all the right answers and then rank them first, second, and third. And remember, we rank things based on ABCs, degree of threat to life, and so forth. Not, well, I think I would do this first and that first. Okay, we do it based on safety, safety, safety. Okay, so mom, if she's 20 weeks and we do a glucose tolerance test, then she has gestational diabetes if it's after 20 weeks. As far as the glucose tolerance test, remember they do a 2-hour GTT. If the 2-hour GTT is abnormal, then they do a 3-hour GTT. If any of the levels during that 3-hour glucose tolerance test are abnormal or outside of the norm, then she has gestational diabetes. Depending on how high her sugars are, they may start with diet, but if they're too high, they will put her on insulin because, of course, her sugar match is she's doing the blood sugar for her and baby. So my mom has gestational diabetes and I'm got her on insulin. What puts people at risk for diabetes in pregnancy? Obesity is one. Uh, Renal failure, kidney problems can contribute to that. And certainly if she's got, problems with filtering and so forth, that certainly predisposes her. Um, the biggies are going to be family history, having had it in a previous pregnancy, you're going to get it again. Obesity. Think about the trifecta. The same trifecta always exists. Doesn't matter if I'm pregnant or otherwise. So hypertension increases your risk. Having diabetes increases your risk. Being obese, being African American, Hispanic. So the things that put me at risk for diabetes in general puts me at risk for gestational diabetes as well. If she's got PIH, she's definitely higher risk, things like that. And then, of course, during pregnancy, There's there's several hormones that are in play, but what's the big hormone that makes mom's sugar or makes mom insulin resistant? What was that you learned way back in week 1? It's a key hormone in diabetes. Not prostaglandin. Prostaglandin causes softening of the cervix. Think prostaglandin gel actually makes the cervix start to soften so that it can dilate. Cortisol has an impact for sure. Cortisol causes an increase. I'm looking for HPL. Remember that human placental lactogen? Human placental lactogen, or HPL, is one of the key hormones that can tip women into. So basically, it keeps women in that stage of insulin resistance, because remember, insulin resistance keeps my sugar a little higher than normal, but I want it a little higher than normal to prevent mom from becoming hypoglycemic, because hypoglycemic mom means hypoglycemic baby. So HPL is responsible for keeping mom a little bit insulin resistant as she's going through this pregnancy. And because she's doing that, it's going to, for somebody who has these risk factors, can tip her over into gestational diabetes. Okay. Otherwise, fair game is always going to be questions about insulin, peaks, troughs, what to do when you're sick. All of that is fair game. That is not on my exam tomorrow, but it is fair game certainly for any exam that you have going forward, the final, NCLEX, life, all of that kind of stuff. But all of that is not on tomorrow's exam. Okay, so let's talk about pregnancy-induced hypertension, gestational hypertension. So my mom has high blood pressure and she's 16 weeks pregnant. What does she have? Chronic hypertension. Very good, Lonco. She has regular old chronic essential hypertension. Mom gets high blood pressure and she's 22 weeks pregnant. What does she have? She does not have PIH. What do I need? I need 3 things for me to have PIH. What are they? Three things. What are they?
Is it the
Has to be
edema,
after 20
hypertension, and
weeks.
urine?
Go ahead, Raiden.
Uh, is it the edema, hypertension, and proteinuria?
Very good. Edema, hypertension, proteinuria. Okay, I don't have pregnancy-induced hypertension unless I have all 3. If I have 1, if I have 2, I do not have pregnancy-induced hypertension. Okay, good question, Justin. Isn't that preeclampsia? Yes. Pregnancy-induced hypertension is split between preeclampsia and eclampsia. Okay? Preeclampsia and eclampsia. So you have pregnancy-induced hypertension has 2 components: preeclampsia and eclampsia. Preeclampsia split into mild and severe, and then eclampsia. So think about PIH having 3 parts: mild, mild preeclampsia, severe preeclampsia, and eclampsia. But in order to have any of those, they have to have high blood pressure, proteinuria, and edema of the hands, face, or sacrum. Okay? If I don't have all three, I do not have PIH. I have gestational hypertension if it's after 20 weeks. I have chronic hypertension if it's before 20 weeks. Everybody with me? Okay. So then I break down my mild and severe. Think of it as 4 parts, right? I have proteinuria 1 plus 2 plus 3 plus 4 plus. Okay? 1 and 2 are mild, 3 and 4 are severe. Okay? Same thing with edema. If I have 1 to 2 plus edema, it's mild. If I have 3 to 4 plus edema, it's severe. And when I'm talking about urine output for mild is over 500 in 24 hours, which still is low, but that's the cutoff. And under 500 is severe. It's edema of the hands, face, and sacrum, potentially progressing to anasarca. But what we're looking for predominantly, having edema just in the feet and ankles, that's just normal part of being pregnant. You've got weight sitting on the pelvis and you're decreasing venous return, which causes pooling in the feet. So that is not what we're looking at. We're looking for edema in places that it wouldn't normally be. The hands, the face, the sacrum are the biggies, and then it can be more pronounced to anasarca if it progresses. Okay, after Marissa, after 20 weeks, it is only preeclampsia if they have all three. If they have high blood pressure, proteinuria, and edema of the hands, face, or sacrum, then they have preeclampsia. If they have 1 or 2, but not all three, they have gestational hypertension until they have all three. Then they go to preeclampsia, they seize, then they have eclampsia. Okay? What do I use to prevent seizures? Mag sulfate. What's the antidote for mag sulfate? Calcium gluconate. Very good. What are the big things I need to monitor when my mom is on mag sulfate? Yes, there's lots, but there are 2 biggies that are your priorities when they're on mag sulfate, aside from the mag level.
DTR.
What'd you say?
DTR.
Deep
DTR.
tendon reflexes is one. Respiratory rate and urine output. Respirations, urine output, deep tendon reflexes are the biggies. Okay? Their urine output will go down, their respirations will go down. My mom's in trouble, aside from my mag sulfate. But remember, I'm not going to get a mag sulfate instantaneously. So I have to look at these other physiologic parameters. So changes in those deep tendon reflexes, decrease in respirations, decrease in urine output. I've got to be thinking mag sulfate toxicity. Okay. What else? And of course, we treat them with antihypertensives. Do we give ACEs and ARBs to pregnant women? What's first line treatment for pregnant women?
Labetalol?
Labetalol, the beta blockers. Very good. Beta blockers are first line. Beta blockers are first line for a couple of reasons. ACEs and ARBs are contraindicated. They can cause problems, but They can cause problems with the baby, but beta blockers are a safe drug for a couple of reasons. They have a very large range in dosage that we can give, but beta blockers do not cause steep declines in blood pressure. In other words, I don't give it and the blood pressure plummets because it's a very modest decrease. It's dose dependent as far as the drop that I get, but it's a very it's a slower process and doesn't just bottom mom out. So beta blockers are always first line, followed by your calcium channel blockers. Beta blockers always end in what? Because you're taking your farm HESI too. Beta blockers always end in what?
Lol.
OLOL, ALOL, or ILOL. Okay. We have lots of them now, so they had to start adding my LOLs. It used to just be OLOL, but now we have ALOL and ILOL. And then calcium channel blockers end in what? Dipine, DIPINE. Think about it, causes a dip in calcium. Okay, causes a dip in calcium. So dipines cause a dip in calcium, so they're calcium channel blockers. Okay. All right, we talked about D cells, newborn jaundice. We talked about RH incompatibility, indirect, direct Coombs. Talked about phototherapy. Let's talk about DIC. Well, just because I don't want to forget, you do have 2 NGN questions on this exam, okay? And I'm going to give you the subjects and I'm going to tell you the strategy for answering them. So the first one is going to be a drop down. And it's going to be your, the subject of the question is thermoregulation. So what happens if my baby is not warmed? What kind of things can happen to my baby? What kind of things do I need to assess for? So for example, my baby is an infant of a diabetic mom. And an infant of a diabetic mom, we know, can have problems with thermoregulation or the ability to maintain their body temperature. And because of the inability to maintain body temperature, certain things can happen. Okay, so that's what the question is about. And it's going to ask you about what kind of things happen. That's going to be a drop down, and you have choices. So it's not fill in, it's blanks, but has a drop down for what kind of things can happen. You have a slide about this. I'm just going to tell you. You have a slide that directly relates to this question, related to thermoregulation, specifically for an infant of a diabetic mom. And then the next part is how am I going to help to solve the problem that I identified? Okay. The second question is going to be a patient who is coming in for their follow-up after having their baby. So I think it's 2 weeks later. And it's going to give you one of those grids that you love to hate, but it is a part of life when we're talking about next step being NCLEX. So it is one of those boxes that asks you effective, ineffective, not related. Okay, so it is a mom who comes in for her 2-week follow-up. At her 2-week follow-up, she says, you assess these things. Does that mean that things are going like we expect? Then it's expected. Is it not what we would expect in a 2-week-old or 2 weeks after or into postpartum? Then it's ineffective, or is it completely unrelated? So for example, one of the things says that she's complaining of seasonal allergies. So is that effective postpartum, ineffective postpartum, or unrelated? Unrelated. Doesn't have anything to do with postpartum. So that's how you answer the question. Do not overthink it. That is what it's asking you. Is this what I would expect postpartum or not? If it is, it's effective. If it's not, it's ineffective. And you already know the one that's unrelated. Okay? All the rest are either effective or ineffective. And it's just, is this normal postpartum or not normal postpartum? That is it. Okay? So don't overthink it. It is not a trick question. It is exactly that. Is this what is normal postpartum or is this not normal postpartum? Okay? Don't add to it. It's just what it says there. If it says my temperature is 98.2, this is normal, so it is effective. Okay? Don't go, well, I don't know what her temperature was before, so I don't know. No, is that a normal temperature? Is it not a normal temperature? It's effective. Okay? Questions about that? Okay. What else on this list? We have 15 minutes. So what else on this list is your heart's desire?
Miss Tina, can you go over dysfunctional labor and
Okay.
yeah,
Go ahead. Dysfunctional labor and?
and the preceptor's labor?
Okay. So dysfunctional labor includes a lot of things. There's actually a slide towards the end of the complications PowerPoint that specifically talks about it's either the postpartum or I think it's at the end of the postpartum one that talks about dysfunctional labor. The word dysfunctional labor is anything that means labor's not progressing like I expected. So there's lots of things that can cause that. Cephalopelvic disproportion, large babies, multiple fetuses, the failure to progress. Mom goes to 7 centimeters and labor stops. Okay, things like that. So the thing about dysfunctional labor is it depends on what's causing it. So if, for example, my mom gets to 7, her water broke and she is sitting here and she has she's not having any contractions, labor has stopped, we've given her Pitocin, still not doing anything. What's going to happen now? She's going to end up with a C-section. Okay? If how about if I have a mom who's sitting at 5 centimeters and labor has stopped, her water has not broke, and what would you anticipate we're going to do for her? Very good. I'm going to do an amniotomy because you picked up on something important. Her water had not broke. If her water hasn't broke and labor's not progressing, easiest way to get labor going is to do an amniotomy. Now, if my woman, her water has broke and she's at 5 and not doing anything, then what would my intervention be? Come on, you know. Yeah, so I have a woman who also at 5 centimeters, but her water already broke and her labor isn't going anywhere. Now what is my intervention? Yeah, I'm going to induce her with Pitocin. Okay? Now, what if I'm giving her Pitocin? Her labor now is going, her contractions are too long and too strong. And she's on Pitocin. So her labor is also dysfunctional, but now her labor is too hard. Now what's the intervention? Stop the Pitocin and prep for a C-section. Very good. So dysfunctional labor has to do with all kinds of, there's a list of all the things that could cause dysfunctional labor, and your intervention depends on what is your situation. Okay? Now, in terms of oh, I was waiting to see what Benacar was going to say. Okay, so that was dysfunctional. Okay, let's talk about precipitous birth then. So precipitous labor, precipitous birth. Precipitous means fast or abnormal, okay? By definition, a precipitous labor is one that basically happens. So think precipitous labor like the stories you hear where the woman, in fact, this happened last year. The woman was on an airplane and she went to the bathroom because she thought she had to poop, and she ended up birthing a preterm infant. She didn't know she was pregnant. That's a precipitous birth. Okay? Nothing was happening. Woman wasn't in labor, and boom, I have a baby. Okay? Sometimes she knew it was coming, or she knew she was pregnant, sometimes not. But that's just a really easy example. Another example is a woman starts to have contractions. Maybe her contractions are, 20 minutes apart, and then hour later, out comes the baby. And her labor didn't get more frequent, it didn't get stronger, it just was, this slow labor, but I have a baby that's born. That's a precipitous labor. It's a precipitous birth. A precipitous labor is a labor that from start to finish is over in less than 3 hours. Okay? So that comes with a lot of women are like, yes, that's what I would like. The answer is no, you don't really want that, because is our body made to do that?
So what do we need to assess the newborn baby in this situation?
Okay, so the assessment as far as the newborn is just like any other. Now, this may or may not be a preterm infant. It could be a full-term infant that mom just happened to dilate without knowing it, and out pops this baby. Oftentimes, though, it's a preemie baby. But as far as assessment or postpartum assessment, your assessment's going to be the same. You're assessing the physical characteristics of the baby and determining, approximate gestational age and or characteristics of what makes this baby preterm or postterm, and providing care accordingly. The problem with precipitous labors and precipitous births is our body's not made to do that. Okay? So particularly a precipitous labor, you're talking about somebody who basically goes from zero effacement, zero dilation to delivery in less than 3 hours. Our body's not made to do that. Our body is made to go through a process. That's why we have the latent phase, the active phase, transitions, and then we birth the baby, and then we have birth the placenta. We're talking about doing all of that in less than 3 hours. And so you're basically talking about a very hard, very fast labor, and that comes with consequences for mom specifically, where you're looking at things like lacerations of the cervix, lacerations of the vagina, lacerations to the perineum, possibly, bruising, edema, injury, things like that, that we don't have when labor has this process over time. Yes, Marissa? Right. It's so fast that the body's not ready, so you can tear and rip and all kinds of stuff. Okay, postpartum depression, postpartum blues. Most women get postpartum blues. Happens usually within the first 2 weeks, and it has to do with we all think that we're going to have no problem. It won't be that big a deal. You just get up and feed him and go back to sleep, and then you bring home a baby and you realize you're doing this every 2 to 3 hours, 24 hours a day, and that it won't be any big deal becomes a really big deal, where we're in that adjustment phase. And so it's very common within those first couple of weeks that mom feels overwhelmed, that she's tired, that she's irritable, that she's possibly having emotional outbursts and so forth. And then if she gets a little support, somebody comes and says, let me take care of the baby while you take a nap, then she's fine. When it becomes postpartum depression is when we start getting at 3, 4, 5, 6 weeks or more, where mom rejects the infant. She's not taking care of herself. She's not taking care of the infant. She's trying to pass off the infant. She's not meeting the infant's needs. She's not meeting her needs. She's threatened to kill herself, to kill the baby. And of course, there's the whole range in there. Typically, the treatment for postpartum depression is medication, simply because postpartum depression exists because of the hormones not going back into sync exactly like they need to. And it takes too long to do talk therapy to get a response. And so the typical treatment is going to be medication. So it's really about what is your, what do you see and so forth. Okay, what is your contradictory information about PIH? I asked Dr. Manal and she put PIH is when the mother shows hypertension after 20 weeks. That is true as long as she meets the requirements for PIH. PIH has to have high blood pressure, proteinuria, and edema of the hands, face, or sacrum. If you look in your PowerPoint, I have a slide in there and it's very specific and shows you the arrows of this is gestational hypertension, this is mild preeclampsia, this is severe preeclampsia, and then of course what the eclampsia is. So you have a slide that very specifically talks about gestational is when they have high blood pressure without proteinuria and edema of the hands, face, and sacrum that occurs after 20 weeks. PIH is either mild or severe with proteinuria and edema. They must have all three to have PIH. And you have a slide that gives you a picture. Okay. Safe medication for postpartum depression is going to be your SSRIs. Particularly Prozac is the #1 drug of choice because it's been the most studied in pregnancy. And in fact, women who have post-traumatic stress from, like, let's say a woman had a really horrible delivery and stuff with a previous pregnancy where maybe she had a crash section and there was something wrong with her and the baby and lots of things happened and she's got PTSD from it. A woman can be given Prozac during the pregnancy to try to help her work through that. I actually had a friend who had PTSD from a prior delivery that was so severe that she had to start taking medication because she physically could not bring herself to walk into the hospital because her PTSD was so bad. Okay. If you come up with any burning questions, I will answer them before we take the test tomorrow. But I think that's most of it. Changhui, we got like 3 minutes. Do you have a question, Changhui?
I'm so sorry. I muted my mic. So yeah, do you remember we need to go over DIC?
Oh, DIC is basically overclotting. So they clot in all the little micro arteries. So depending on where the clots are is what mom can have. So if it's in the heart, she can have a heart attack. If it's in the brain, she can have a stroke. Her kidneys can fail. She can have all kinds of damage to her major organs. And so she clot, and then she runs out of clotting factors, and then she bleeds out. Okay, so then we have a hemorrhage problem. So first we have a clotting problem, then we have a hemorrhage problem. So when she's in the clotting phase, we give her heparin to stop her from clotting anymore, but also from the clots getting bigger. And it really is supportive care, trying to keep her alive, right? We want to stop her from clotting. We also want to stop her from bleeding out. So it could be that we're giving her clotting factors back, or we're giving her blood, we're giving her fluids to up her volume so her pressure doesn't drop. She's in a serious condition. You just need to know the basics, and then you know what it's not. Like, your patient with DIC is not going to have symptoms of a DVT because it's not a venous problem, it's an arterial problem. She's shooting out clots into those micro arteries. So I'm not going to get a one-legged DVT. I could get a pulmonary embolus, I could get a stroke, or anything like that. There's one question about DIC. Okay? All right, that's all the time we have. I have more students to meet with. So I will see you bright and early in the morning. You're welcome. See you in the morning, you guys.